We're going to talk about leishmaniasis now. Leishmaniasis actually has kind of three different clinical forms that we'll go into at the end of the video. But the first thing to know about leishmaniasis or leishmania is actually that this is the result of a parasitic infection. Specifically, the organisms that cause leishmaniasis are obligate intracellular parasites. And I don't think we don't often think about intracellular parasites. When we think about parasites, we think about these, um, I think about worms, these large, unwieldy eukaryotic organisms. And that certainly is true. But some of the most problematic parasites actually are intracellular. And Leishmania would certainly fall into that category. Okay, so main characteristics. I already said this one. It's an obligate intracellular parasite. Um, we are able to transmit this one human to human or animal to animal, and there is actually a significant animal component to the life cycle, kind of depending on the geographic area. But the initial kind of introduction into a population actually is the result of arthropod vector. And the arthropod vector is the female sandfly. So an animal in a population gets bitten by a female sandfly, and that kind of can set off this larger life cycle. We're going to focus on two strains of Leishmania because there are actually a lot of different species that infect humans, and they cause a really wide range of disease. I also want to note, just before I forget, that actually, if you're a sketchy medical or sketchy micro fan, the Leishmania video is very good. I looked for it on YouTube. It's currently not one of the ones that's available there. But if you have a subscription to Sketchy Micro, I would actually recommend checking that out because it's actually a very good resource. Okay, so the two species that I'm going to focus on in this video are actually L. donovani and L. brasiliensis. L. donovani is the cause of visceral leishmaniasis, as well as mucocutaneous or cutaneous or dermal leishmaniasis, whereas L. brasiliensis really is more known for causing cutaneous and occasionally mucocutaneous. And they also have like slightly different geographic distributions, okay? So with L. donovani, we're more likely to see that in Africa and Asia, maybe the Middle East a bit, whereas Central and South America are more associated with the one that sounds like a South American country, Brazil. Okay, as with most parasites, I don't expect you to know the entire life cycle off the top of your head, but I do want to talk about kind of some important points. So I want to reiterate this concept of reservoirs and vectors, okay? Reservoirs are where pathogens hang out, but don't necessarily cause disease. When we think about kind of pathogen fitness, this is where I would say, like clinically, and microbiologically, there's a difference. So, as a microbiologist, I think a good pathogen is a pathogen that doesn't kill its host. Because if we're thinking about this from the standpoint of survivability and prolongation of the pathogen's species, if it kills its host, it has nowhere to live. It burns down its house. But clinically, I think people often think of a good pathogen as something that's really damaging, that's going to be super pathogenic and cause disease. So there is kind of, I think, this disconnect. So in my mind, reservoirs are the place where a pathogen is kind of on its best behavior. It's maintaining its own home. So this is where we can find kind of a pool of that pathogen that can then be like picked up by the vector. So, for example, in domestic animals, dogs, cats in these endemic areas certainly would potentially have leishmania in the population. There are also wild animals, possums, anteaters, sloths, and even humans sometimes are considered a good vector, kind of depending on, or reservoir, depending on the severity of disease. I already mentioned the vector before. There's the female sandfly. So basically a bite from an infected female sandfly will be enough to develop disease. And that's pretty much what happens. So we have an infective form. The infective form is the promastigote, okay? The promastigote, basically it infects you when it is consumed from flesh or blood of an infected reservoir, okay? So basically the fly actually ingests the tissue or blood of the human or the animals. So this could be a cat or a dog. So the sandfly takes a blood meal and then becomes infected, okay? And then they actually deposit these back into our blood when they go and take a blood meal later. So it's basically placed back into our blood. The diagnostic stage is actually the amastigote. And I actually like when drawings actually match reality, which is what I'm kind of showing here. So this is an amastigote. Here, this is amastigotes, or many amastigotes. They're found intracellularly. So this is a macrophage, and all of these little red dots are your amastigotes. And you can basically, they're collected from aspirates of bone marrow, skin lesions, spleen, lymph nodes, which then you can spread on a slide and you can see it very clearly. So these red speckles in the cytoplasm. These are actually parasite nuclei in the cytoplasm of the macrophage. So it's very clear. And then eventually what would happen is if this macrophage got too full of amastigotes, it would rupture, and that would actually release the parasites out, and then they could be picked up and ingested, and then the cycle would go on and then on from that. And this actually can be kind of seen pretty easily pathogenically as or pathologically, as I'm showing here on this slide. All right, so we've got 3 clinical syndromes here. The first is visceral leishmaniasis, which is actually what I'm showing right here. There's approximately 500,000 cases per year. 90% of these cases are found in areas like Bangladesh, Brazil, India, Nepal, and the Sudan. This can be a rapidly fulminating disease in 100% of untreated patients. So if you're untreated, it can be really fulminant very, very quickly. The incubation period is kind of variable. The incubation is anywhere from several weeks to even up to a year, kind of depending on a lot of factors, including patient health. There is kind of a gradual onset of fatigue, diarrhea, anemia, and then chills and sweating may present. And it kind of tends to resemble malaria in its symptoms. And that's problematic, right? Because malaria is something that we expect to see in these parts of the year of the world. As the organisms proliferate and invade the cells of the reticuloendothelial system, hepatosplenomegaly becomes evident, and you might even see like some weight loss, emaciation, kidney damage occurs as the cells of the glomeruli are affected. And so you kind of get this persistent disease, and then eventually you can get this persistent disease of the skin, where the skin becomes hyperpigmented, and then you get these lesions, which are shown here in this picture. The lesions have given the disease the name Kala Azar in India, or black fever. The symptoms of the fever include all of the things I've kind of already mentioned: hepatosplenomegaly, weakness, pancytopenia. These are all commonly associated with visceral leishmaniasis. If treated, the patient may still experience this post-Kala Azar dermatologic condition, or leishmaniasis, which is disfiguring, and that's these multiple nodules on the face and body here. Okay, so then the other 2 forms that we actually associate with leishmania, these would be cutaneous leishmaniasis and mucocutaneous leishmaniasis. So cutaneous leishmaniasis actually appears at the site of the fly bite, and that happens about 2 weeks to 2 months after the initial exposure. And the lesion just becomes intensely irritated and pruritic, and then it can enlarge and it can ulcerate eventually. Gradually, it's going to harden and kind of crust over, which this one is kind of beginning to do. It'll have this thin serous material. What this one is kind of also known for is that you get these secondary bacterial infections, which can complicate disease. So basically, we all have bacteria that lives on our skin, and as that becomes irritated, it is, especially if it's ulcerated, it's an open wound, and so we can get bacterial infections in the wound as well. The lesion might heal without treatment in a matter of months, but typically it does leave a disfiguring scar. So that's even though it'll heal, there is unfortunately a long-term effect from it. Okay, mucocutaneous leishmaniasis. This is actually produced by L. brasiliensis more than L. donovi. So the incubation period of basically you get these primary cutaneous ulcers, and they're similar to those found in other forms of cutaneous leishmaniasis. Basically, the essential difference in clinical disease is actually the destruction of the mucous membranes and the related tissues, which is kind of what I'm showing here. Basically, untreated primary lesions might develop in mucocutaneous forms in up to about 80% of cases, and then they spread to the nasal and oral mucosa, which is what I'm showing here, obviously, and they can become more apparent or concomitant with the primary lesion, or they can occur many years after the primary lesion heals. So the mucosal lesions, the other thing to keep in mind is these aren't going to heal spontaneously the way the cutaneous lesions might. So they often result in kind of this severe and disfiguring facial mutilation, and unfortunately often death as well. All right, so let's talk diagnosis, treatment, and control. So in an endemic area, you can pretty much diagnose leishmaniasis kind of based on clinical symptom. So you don't necessarily need to wait for a definitive diagnosis. It kind of is. But if you need to do a definitive diagnosis, you're going to need to look for those amastogotes in clinical specimens or promastogotes in culture if you're actually culturing the parasite. You can do this by looking at properly stained smears from touch preparation or ulcer biopsy specimens. You can also do culture of ulcer tissue to determine diagnosis of cutaneous and mucocutaneous leishmaniasis. Specimens for visceral leishmaniasis include things like splenic puncture, lymph node aspirates, liver biopsy, buffy coat preparations of venous blood. So there are a lot of varieties of tissues that you could potentially use. You can look at things microscopically, you can do culture. There is also DNA and RNA techniques, but those tend to be a little bit expensive. Serologic tests don't tend to be useful. There's kind of a lot of different exposure to this, so they're just not, they're not a good indicator. As far as treatment goes, it's a little bit of a mixed bag. So for cutaneous leishmaniasis, you can do systemic treatment for cutaneous leishmaniasis using stibogluconate, and that has good efficacy for reducing progression to mucosal disease, so if you catch it early enough. Amphotericin B is also a good candidate, but it's a little more toxic, so we don't use that as often. For visceral, though, amphotericin B is a good option. Actually, another one is miltefosine. That was actually the first FDA-approved drug, but or I guess not FDA-approved drug, but that was one of the first drugs that was approved for treatment of visceral leishmaniasis. And then for mucocutaneous, it's not really a surprise. It's basically a combination of these three because you're going to kind of throw things at it and see what you can do to treat it.